Hello, everybody. I know you were expecting to see Trudy, but it's only me today because of technical reasons. For those who don't know me, I'm Livia Martucci. I'm the academic secretary for the perinatal faculty, but I've been asked to talk with you today because I'm also the clinical lead for the community perinatal services in SLAM, and we thought that today we would focus on changes that have been implemented in some of the community services. We haven't had any questions written to us so far, and likely questions will be answered in writing when they reach Trudy and Giles. But if any questions come through live and I can answer them, then of course I will. I'm sure that much of what I'm going to say is already being put in practice and thought about, but we thought we'd share things that we found helpful in many parts of London. And we know that this might not always be relevant, and appreciate that rural areas might have different challenges, but hope that it will still feel useful and reasonably relevant for the rest of the country. We will also hear from Harriet from the Perinatal Quality Network, and hopefully from Selina in Scotland. And also, just for everybody to know, we are drafting some guidance for service users at the moment to be issued from the college, and they should be available soon. So what I wanted to start with were some thoughts about, first of all, our patient group, then concerns around the changes to our assessment, and then thoughts about staff planning and staff morale that we have found consistently across perinatal services, at least in London. So we have found that many of our patients seem to experience increased anxiety during this time, partly because of the lockdown and partly because of fear of either becoming ill or a loved one becoming or being ill. And in London, we have been receiving referrals for people with COVID-related anxiety. And the likelihood is that these will increase in the coming weeks. Also, many women are very worried about the changes to their birth plans and not having birth partner presence as much as they would have wished. They are saddened sometimes and distressed because they have to change their plans for early postnatal period and maybe longer than that. They had a whole idea of what their maternity leave or postnatal period would look like, and the children's centers they were going to go to, and the friends they were going to meet, and the family that they were going to share this with, and a lot of this, of course, has changed, and that is taking its toll on many of them. For some, it's more than that. They were counting on family and sometimes friends to help with childcare so that they could sleep and rest and have more of a balanced lifestyle still that would help them not to relapse, and that is potentially not possible anymore. So there's an increased risk of relapse, which can make them more anxious. In some of our teams, we have reviewed our care plans to ensure that this is taken into account for the women where that was going to be part of their early postnatal period, sort of relapse prevention planning. In general, we have found that most of our women feel that it's important to know they're not losing the input and care of their perinatal services, even though there isn't as much face-to-face contact. In London, many community services started offering telephone or remote web reviews prior to the lockdown, because that way they reduced their traveling using public transport and exposure by attending health centers. And because this reduced traveling times, both for women and for professionals, it seems to actually have made attendance to these meetings easier, and we have found that we can be in touch with women more often, which in turn seems to help them. And the feedback we have received from many of them is that they feel relieved that they are receiving remote contact rather than face-to-face, because that way they can minimize the risk of infection. One thing that we have found can be helpful is to make sure that we are aware and we can share with women and families the resources that many children's centers have made available online. And for those who have children in nurseries that have now closed, we tell them to check what resources their nurseries have put online potentially. Another part of the things that we've considered, of course, are the quality of our assessments when they're not done face-to-face. Telephone reviews can make it especially difficult to include the baby in the review and to get a picture of the infant development and behavior and the parent-infant relationship. So for people where there is a specific issue with poor bonding, or where there is a suspected or confirmed attachment disorder, and these are significant issues, perhaps remote reviews with a visual platform are prioritized and should be used in preference where possible. It's not always possible. Some people have wondered about preconception advice. What we have agreed is that we should still offer preconception advice whenever possible. If anything, the lockdown might increase the number of pregnancies. People will still think about having a baby, and if they are on a complex medication plan or they are on a high risk of relapse, they should really be receiving our advice, and things and planning would change now for people who are taking lithium or clozapine. So it remains very important and valuable to provide this service if we can continue to offer it. Another issue that we have been thinking about and facing is that of safeguarding. Safeguarding agencies are also raising their thresholds for intervention significantly, and this sometimes may leave us feel concerned about children and babies who are in our caseloads. So it's important, it has been important for us to ensure that we have contact information for the safeguarding leads in our trusts, and that we have contact also for the senior managers in our local children and families department and vulnerable adult departments, in case the social workers on the ground become ill and they have to disengage from the case, at least for a time. And in this way, hopefully no concerning case will slip through the net. Same goes for domestic violence. We know that the lockdown has increased the rates and risks of domestic violence, so it's important to make sure that we are all aware of what resources can still be offered to women. At the same time, we need to remain very pandemic conscious, so we have been encouraging remote safeguarding and professionals meetings wherever possible. And keep in mind that if the pandemic has not yet broadly or visibly spread to your area, then you have a really great opportunity to begin working more remotely so that you can minimize the risk of infection as much as possible. From the point of view of planning around staff, we have prepared to working remotely and having the right equipment such as laptops, remote access, virtual platforms, if these are used, telephones, etc. And we have, many of us, moved to remote working, considering only skeleton staff at team base for duty and a senior presence. It's important to make contingencies for staff sickness and absence with line managers, and to discuss expert consultant cover wherever possible in case a consultant become ill and have to not be available for a time. If it's feasible, you can consider merging duty rotas between 2 community services or more, so that key workers don't have to attend as frequently, and so that you can increase the likelihood that someone will always be on duty, and that possibly there are more than one key worker on site at any given time. We thought that it was very useful and think it's very important to carefully review the caseloads, so that there is a clear plan for each patient that also covers crisis options and the potential need for acute services, and what to do in case their key worker or their doctors become ill. The other thing that is important to consider is the threshold, both for assessment of new cases and for taking new patients on for ongoing care. Many community services have raised their threshold for ongoing care, but in some services there has been a slightly lower threshold for an initial assessment, so that we could offer advice on a care plan and then return the patient to primary care. We have seen more referrals about COVID-related anxiety, but actually in many parts of London we have seen an overall decrease of referrals, and we are concerned that women who need our care might not be referred to us, because right now so many of our usual referrers are with their mind somewhere else. So many trusts are writing to their referrers, or already have, to advise them to keep referring women with SMI and with a history, either personal or family, of puerperal psychosis. And we, many trusts and services have written to women themselves to assure them that we continue to care for them, and to explain why it's important that they still access our service, even if they're stable and well, to minimize risk of relapse and of having to go into hospital. It's important also, we thought it was very useful to know how other services around us have changed their way of working. That includes, of course, the acute wards, the MBUs, the home treatment team, liaison, safeguarding agencies, and also IAT, and whether it's possible to do more joint working, especially with IAT, because some IAT services found that their rate of referral also had decreased, so they actually have quite a lot of availability to take people on for targeted interventions. Reviews on the postnatal wards in most London maternity departments are now only happening if women are acutely unwell rather than as routine, and prolonged admissions are not advisable really, and side rooms are really not available. So women are discharged as quickly as possible as soon as they're obstetrically stable. That means that they can be reviewed remotely by their key worker or their doctor on day 2 or whenever it was that it would have been planned, and then their ongoing reviews can happen remotely if needed. So it's important to make a new plan with your maternity department to make sure that the new protocols of care are clearly laid out. I'm sure most of you would already have taken care of this. The other issue that is, if anything, more important, but certainly just as important as everything else, is that of staff morale. These are very stressful times, especially for those of us who keep traveling and work at team base. So it's really important that everybody look after each other, and that there are frequent, if not daily, meetings where we can talk about how we feel about all this, about these changes, and what worries us and what seems to work as well. Some services have increased their capacity for reflective practice, for externally facilitated reflective practice. This could be considered if it is an option. It's important that all of us take leave as we had planned to do it. This is, we keep hearing it, but it's true. This is a marathon, not a sprint, so we must take time to rest and recuperate during this crisis. And it's important, if at all possible, to completely switch off while we're on leave. The other thing that has been worrying people among members of staff is the possibility of being redeployed. Of course, we are all aware that this can happen, but at least in our trust, I think also in other trusts, there's an increasing recognition that community services are very important, and that their contribution is that of keeping people out of hospital, which right now is essential. As the perinatal population is considered high risk, both psychiatrically and from a COVID point of view, I think there are a number of trusts where perinatal services are considered essential and kept going as much as possible. The other thing that we have found helpful, and we think everybody would find helpful, is to look outward to maternity services and also healthcare staff in the acute trust that is connected to your service, who potentially are in need of expert mental health specialist input, who might be struggling. We are all fairly aware of what is being made available to our colleagues in the acute trust, and they know that they can get in touch with us if they think that this will help them as well. And last but not least, the college has made a number of resources available. To start with, I'm sure everyone is already familiar with PPE guidance, but there is a link on it through the college. There are CPD and e-learning pages, and there's an e-learning hub for members with COVID-specific resources that can be looked at, and there's also well-being advice under the workforce tab. So please make use of these resources if you think that they will be useful, and pass them on to other people if they don't know that they're there. So I have said most of what I wanted to say. So the last thing I want to say is that I will hand over to Harriet from the Perinatal Quality Network. And perhaps at the end we can take any questions, if there are any questions live. So I'm now handing over to Harriet, if you want to tell us about the Quality Network.
Great, thank you. So I'm Harriet Clarke. I'm one of the heads of quality and accreditation here at the college, and in particular I work on the Perinatal Quality Network. As a team, we're very keen to provide as much support and guidance and advice as we can during this time to services. A lot of you might be aware already that we've postponed all of our peer reviews and face-to-face events, but we are planning to run a series of webinars for our members that can be used as a platform to sort of share ideas and experiences around COVID issues, and to ensure that we make the most out of our network's community. They'll be focusing on a range of different topics, but also aimed at a range of disciplines as well. So we're hoping to cover a lot of different things within those. They'll be promoted shortly through the network, but while there'll be live webinars, we're also hoping to record them and make them available afterwards to ensure that people can watch them at a time that's most suitable for them. In addition to this, the college has also launched a COVID-19 mental health improvement network with an aim to create a supportive learning community and another space to share learning among different services. So this isn't perinatal specific, but it does have a perinatal component to it. And by being available to all different services, it means we can really learn from each other and different types of services around what each other's doing at this point. On this network, the new network, you can share your own experiences and challenges, but also share different resources you might have, policies, procedures, guidance, add these things to the library for all members to be able to benefit from them, but also means you can access what other people are sharing. And you'll also be able to contact other members privately if you wanted to gain extra networking opportunities to learn more about what other services are doing at this point. To join this network, you need to send an email to it's COVID-19 network at rcpsych.ac.uk. I might ask Kitty to circulate that email address to make sure that everyone has access to it. So I think that's most of the things we're currently running on the network. Perinatal chat will still be used to advertise and promote any upcoming webinars that we have. So if you keep an eye on Perinatal chat for future updates on that. So I'm going to hand back to Livia, and I think we're then going to look at any questions.
Great, thank you so much, Harriet. That was really useful. I think we have a few questions. Let me see if I can figure out a way to see them. I have a question from Mariam, who asks whether it would be possible to share some of the online resources that we share with our patients, such as material from nursery, domestic abuse, etc. The answer is yes. We will share them. Keep in mind that a lot of this information, however, is local resources in a specific territory. So things like information in general and general advice are pretty much the same, but specific things about what's on offer locally is very much about your local area. The other question we have is from Becky Horn from Norwich, saying, with the majority of cases being now managed remotely, do we need to think about the guidance on when a face-to-face assessment is needed, and with appropriate PPEs, of course? There's been an increase of postpartum psychosis, and the issues of managing things remotely is that risks have not been assessed as clearly. And one of the cases then resulted in somebody needing an acute hospital admission. And the concern is that mental health risks remain and are potentially increasing. So do we need to think about how the management of high-risk cases in the community means that we still need to do face-to-face? It's all I think a balancing act of risks, the risk posed by the pandemic versus the risk of acute deterioration. A lot of it is left to clinical judgment. What some trusts have set up, what at least has been set up in our trust, is joint meetings for clinical decision making among different specialists, and cases where there's a difficult decision to make, either from an emotional point of view or from a risk-related point of view, can be discussed in that forum, so that there can be a consensus on management and how to handle this kind of difficulty, so which risk supersedes the other. I think the college had issued some advice a few weeks ago on how to prioritize seeing cases. So when there is a risk of acute deterioration and nothing can replace face-to-face, and such as in the case of a potential psychotic breakdown or need for a mental health act assessment, then face-to-face should be considered appropriate with the right PPE. there might still be circumstances where it's not recommended, and I know that in some parts of London and of the country, they are considering remote mental health act assessments. So everything is changing and is in flux at the moment. But in answer to your question, Becky, I think there never will be a completely precise, specific guidance. But what we have found helpful is ongoing discussions about cases with other expert senior clinicians to reach consensus on difficult decision making, case by case. I hope that answers the question. And Kitty has just posted the guidance for clinician issued by the college as well. I don't know that there are any. Are there any other questions? I can't see any more questions. So I think questions are finished. I wonder whether we should leave things there, or should we wait another minute or two to see whether anyone else has any questions? Okay. Well, perhaps, Harriet, what do you think? Should we maybe leave things here if there are no more questions? And thank you to everyone who attended. I hope that this was useful. Please feel free to get in touch through Kitty if you have anything that you think you would like to ask me and Harriet. And I hope you all have a happy Easter weekend. Stay safe and stay well and look after yourselves. Bye-bye.